So good morning again, everybody. I'm Lee Rickles, Head of Programmes and Informatics at the Trust, and I'm going to give you a little bit more detail of what we're planning to do over the next 4 years to implement the strategy. And now that ties into what we're going to cover today and some of the, how we've got some of the suppliers, what they're going to present and how that ties into the roadmap. And also it'll give you a better understanding of what is that 4-year plan. What are we expected to do? We're not saying it's perfect, but it is a plan. So if today we do pick up on any issues or anything, or when we've got the workshops or the demos, as other issues have come up, do use the opportunity to feed back, because we can change a plan, we can change what we need to do if it makes far more sense. The actual strategy was signed off on the May board, I'm pretty sure it was the May board, and it was very positively received actually, but that's only setting the scene. There's still a lot of work as an organisation we need to do, especially to deliver that strategy. So, okay. What we did set within the strategy was the success criteria. How do we know we've actually achieved it? Is it just something we say, let's just have integrated working, the records will all be there? We've been trying to achieve a lot of that for a number of years now, and we really haven't got anywhere near as far as we would have liked. But one way of making sure are we achieving it or not achieving it is we have actually set ourselves a particular direction and a particular approach. First one in there is moving from NHS mail, from the local email to NHS mail. Bit more of a corporate thing, but email impacts everybody in the trust just about. It's love it or hate it, email's here, and we're using it. Benefits on NHS mail is there's a lot more capability of sharing information. A lot of our partners are utilising that. We probably need to have a discussion with Hull and East Yorkshire hospitals as well, how we do that secure side. I know they're reviewing what they're doing. But you know, the first one on that list that we've got up there, you know, is happening. So I might be opening the floor a little bit here. Any feedback on NHS mail? Fabulous. If there is anything particular, I can catch up with you later on. I mean, if there is something, do catch up with me, because we need to make it sure it's as smooth as possible, the migration. The key one we've got, and it was one that we set out when we did move to Lorenzo, is move into that paperless working. In a lot of areas in the System 1 services, especially on the adult side, we were already getting very close to paperless working. Even to the point that in a number of areas we've gone to the electronic case notes projects is actually moved. When we're getting the patient held records back, that's all getting scanned into the system now, so we don't hold a paper record at all for the future. We've got it all electronic and accessible and such. With Lorenzo, we've still got a large amount of work to do. The system we've got now is actually far more capable than the system we got on the 28th of May 2012 when we moved. We need to start using it far more effectively and far smarter than we currently do. And in a number of ways, and we'll probably come onto this slightly later, there's the mobility issue. It is possible to use Lorenzo mobile as a mobile system. The challenge there is we know for well our infrastructure for 3G, 4G, all the fancy stuff, so you can have a device out in the darkest of the East Riding, where there's, you know, a farmhouse, a sheep and 2 cats or something. You're not going to get any connectivity in there. And to the same degree, in certain areas in Hull, very poor connectivity. We do have a challenge here. So how do we make that work? Because the current way we would normally access it using particular devices doesn't work. We've got to look at other options. And part of that with going paperless and Lorenzo is something we'll cover later on today during the demonstrations with Total Mobile and the solution that's been built there from the Nurse Tech Fund 2 monies we got to basically have a disconnected mobile working solution that works on iPads. So basically what you need to do your day job, if you're on Lorenzo, will move from the annoying bits of paper or rekeying and all that type of stuff to it will be on Total Mobile, and it will all go straight into that one device with the development plan including doing clustering, egrist, The one I would really like to crack, to be honest, with the total mobile solution is when you put your visits in, it also feeds your e-expenses system. If anyone think that's a bad idea, then talk to me later, but I think that would be a good example of we enter in once and use many times for the information we've got. You know, we collect from System 1 where patients are, where we see patients, but we don't use it on our expenses system. That's when we need to start getting a little bit smarter on some of these things. But back to electronic record, we've got to go to that electronic record. There are targets. 2018, urgent care and GPs have to be fully electronic and share the record with patients. We're lucky because we've got until 2020. That's not far away. It really isn't, especially for the changes we need to do. So that's one, and it may not say Lorenzo on the can, but what it will be is, and a lot of the things we're going to cover today, it will be getting to that paperless working with Lorenzo on System 1. One thing that I know John Duckles will talk to me at length and my AM team is standardised use of System 1. We've got so many different forms, so many different ways of working. If you're sharing a record, it's so difficult to understand how everything links together within System 1. It's so difficult to get consistent information because one of the key things on the strategy was how do we start linking the measurement of outcomes for improving patient care, or at least stabilisation if that's all we can achieve, from putting the information in and using the record in the first place. What we don't want to be doing is, I do this bit here, and then I've got to fit a load of outcome stuff in it, and there's no linkage. What we do to provide care directly relates to how we achieve outcomes. So standardisation will help that. And that's the same in Lorenzo as well, but on System 1 we've got to get that consistency and standardisation, otherwise every person's going to work differently in every team. We won't be able to compare, we won't be able to baseline, we won't really know what we're doing, and we won't really know whether we're giving good care or bad care. All we'll know is what we know now is we're doing lots of contacts, which to some degree are meaningless. Having a contact doesn't say we're doing the right thing. Seeing that contact is having a positive impact to that patient and carers is the right thing. And that's why we need some of that standardisation and consistency. Data quality. This is something we need to have a focus on now, but it's got to disappear. It should just be part of, because we've slicked systems up, because it works first time, we don't have to worry too much about data quality. At the moment, it is an issue because there is so many opportunities to go wrong. What we do have is dashboards and information that flags these things so it makes it easier to fix. Some of this, unfortunately, does link back to things like mental health tariff. Them type of methods of funding care are not going to go away. If anything, they're going to become more to the floor. So the better we can get our information into the system and more accurate, so we don't have to fix it and it's sensible, makes absolute sense. But we're going to find probably the next couple of years we're still always going to have that challenge on data quality. We still need to develop the systems we've got. I mean, when we set this strategy, we still wasn't necessarily saying at that point we was going to stick with System 1 Lorenzo. We had put something called an ODU notice out, which is European Office of something, but basically a procurement thing to say, what does the market look like? What's the possibility? And at that point, we still need to get benefits out of what we got before we come to the exit of the national programme. Through the work we've looked at, and really we need to look at organisational change, enabling and empowering, rather than going through the challenge of replacing systems, which if nobody wants to do if we don't have to. If the benefits case doesn't work out, then why do it in the first place? So, you know, as one example, we have moved on that particular part of it, but we've got to look at how we can do it. And the part of the middleware, or the data warehouse and middleware, Total Mobile is an example where we are using the middleware solutions to help us move forward on that particular system. And it won't be the only one. In System 1, historically, difficult to get information out of. And if you are a clinician that uses System 1, you probably ended up with all these extra tick boxes you have to complete on templates to fulfill a commissioner requirement or a contract requirement. The reporting capability of System 1 has improved, and we are investing within the data warehouse to get it to a similar level of System 1. So what I would expect to have in the future is staff manager, senior manager, etc., potentially even patients if you want to push it, and commissioners, you get your dashboards and you get the information that's useful for you. So you automatically get feeds and prompts from using some of these type of things, which we definitely don't have at the moment. If anything, you've got to sort of look, dig, find if it exists in the first place, and does it really help me? Okay, still between until 2016, we've got to transition from the national contract to the local contract. Now, realistically, this may not seem a big issue, but if we don't do anything, come 7th of July 2016, we do not have a contract for a system, so therefore we don't have a system, or Lorenzo System 1. Also impacts some other things we've got as well, but they're the main bits. It's just a hassle you really don't need. So, as previously said by Adrian, we have decided to take a particular direction. Papers are going to the board, this month's board, on the approach we're taking to confirm, can we continue with sticking with the systems we've got, can we deal with the procurement issues, and all that good stuff. We are seen nationally as very much ahead of the game on this one from transition. We did start this in October 2011 because we knew it was coming. A lot of trusts are only just getting their heads around it. And that helps us inform what we're going to do in the future. Purely because if we haven't decided what systems we're going to use, how we're going to invest money or invest time and effort if you don't know what you're going to do, and then you just end up in the we don't do anything situation, which isn't an option. You know, we're in a very challenging time, so we've got to make the best of what we've got and improve what we've got. One bit that will be as part of the workshop today is moving from that static to mobile workforce. Using information technology. That does not suggest that we're a static workforce. Most staff will be mobile, or massively mobile, but what we don't necessarily do is support that with any information. So, simple things such as, I can't get access to the internet while I'm out about if I need to see something, or what about that alert that come on email, or even, can't I just do my expenses while I'm out and about or something, rather than having to go back to base, retype this, do that? Can't I just have a team meeting on the fly using teleconferencing or something like that? You still need face-to-face team meetings, all that type, but it's using technology to be slightly easier, slightly more efficient, more effective, but not for the sake of technology. It's just because it helps, not because it replaces. As I say, we've got the workshops, the activity later today is around agile workforce, mobile working, mainly because two of our key improvement programmes this year are around using mobile technologies. System 1 briefcase, not briefcase, is it mobile worker, and the total mobile solution. And what we can't just do is issue them devices out and say, there you go, there's a load of devices, it's all going to work wonderfully. We've got to change the way we work. We've got to change the way we work at all management layers. So we don't expect staff to have to come back to base all the time to check on them, or to support them, or to understand what's going on. There are other technologies that we can do. If we can do that as mobile as possible, so you have your office wherever you are, and we have spaces for people to be based at and work where they need to, and management can see, and we can do the learn work inside, so we can see where you are visiting patients in real time and all that type of good stuff, then that probably helps work-life balance here for staff. Probably takes stress away from I've got to rush back to base to rekey my data, because if I don't, I'm not going to miss this, do this policy or this professional target. And that gives us an opportunity to work slightly more effectively as a slightly happier workforce and a very much more effective workforce. So the agile work and the mobility bit is key. It's also key when it's linked to our strategy. What we do have at the moment is the Trust has taken a view that we need to invest far more in technology to enable some of this and less in estates. So one thing you may find from the approach we're taking is we can't do everything we used to do with estates because monies are going into technology with a view in year 2, year 3, we don't need all the estate we need for desks and office space, including this building, for instance. We might expand our patient-facing space because we're here for patients, that's what we are here for, but we don't need it because we've changed the way we work. So there is some logic in why we're doing certain things, but it does mean the Trust has to make a number of decisions, and one of them is, we need to do it take that approach. Otherwise, we'll never exit buildings. And we'll still have the nightmare of staff still have to come back, rekey, do this, do that. Not very efficient, very much duplication. I don't think, if anyone really wants to work that way, we'll cover that in the workshop and we'll need to have some discussions. Business intelligence. And I know it says business intelligence because it's a branding, but if you think of this, how do we improve the health of our patients? How can we use the information we've got? We've got so much of it that we don't link together. So we can start saying, actually, doing that particular approach or that particular type of care to that patient group is having an effect or not having an effect. Is it having a positive, negative? Can we see how changes in the overall health community have affected what we're doing, or how by doing changes are affecting our partners? Because it is a joined up system. Although most of the patients we have will not just have services with us, they will have services with all of our other public sector colleagues, and a lot of our systems at this point, I will come to that later, don't join up either. So, you know, we all have examples where you've got to deal with so many different agencies. As Joe Public or patient and carer, you don't understand them. We don't even understand it that well. So let's use some of that intelligence to try and help our patients, care and ourselves do the right things, rather than, unless so, it's around counting widgets, which is basically what we do at the moment. Counting widgets doesn't achieve anything. All it says is we can count widgets. Anyone can count widgets. Actually making a difference and using it is a far smarter way of operating. Using our systems more effectively in Microsoft Office. We've got so many forms, so many things, which have sort of been sticking plaster solutions. Anybody who's done a change form that you've got to do this, that and the other, put this in, email it somewhere else, then somebody rekeys. These are not smart ways of working. The example on that particular recruitment form, we can do it directly in the system. Why don't we? Why don't we do it directly in the system and give the access to people and the authority for people to just do it straight away, rather than we'll fill this form in, use this product, do it this way, that way, because all we do is and then it gets rekeyed by somebody else in the end. So it's another one. How can we move away from some of these sticking plaster solutions we've got with our corporate side and clinical sides to some degree, and make it so we just use the systems as they're supposed to be used? So we can get to that, we just do it once, and it actually makes sense. The information and shared, we've covered that before, I've mentioned it a few times. If we collect some bit of information or we put something in the system, we should just put it in once. There's a very complicated, as I keep getting reminded by the real techie people, way of actually doing all this stuff. Total Mobile are using part of that type of technologies of how you would message between systems and communicate. It's not actually new technologies. When it was done for pathology messaging with general practice and secondary care, we are going back about 15, 20 years. In industry, this is what they was doing 10, 15 years ago. We just need to use it. There's a bit of investment to do that, but that makes everybody's life so much easier, and you know, it takes away that level of duplication. And that's where we need to have, so if we're using System 1 on Lorenzo, you've got to put it into one, and it reads across or feeds in the other. Not we're going to keep doing both. So anybody who's doing the NDT stuff for adults and older adults with System 1 and Lorenzo knows there's that duplication on the MDT recording. We shouldn't be doing that type of stuff, for example. It should just happen. And that's where we've really got to get a lot more smarter and using the integration side. Wi-Fi, that one, to be fair, we're about 99% there. We have got secure Wi-Fi on so many of our sites, definitely, and it is there. What we're not necessarily doing at the moment is linking it into some of the other tasks which will be coming of, if we've got the Wi-Fi in all our inpatient units, why aren't we electronic now, for instance? Our systems will work that way. Most of that is around change of working and to be honest, prioritisation of resources. But to some degree, we've got a good infrastructure. One thing that we picked up last week, on Hull 2020, we've had a real big focus, and East Riding Better Care, we've had a real big focus of how can we have staff turning up at any public sector site and just connect to their Wi-Fi. So you don't end up, I've walked into this local authority building and I'm dead in the water. It doesn't work. The techies have come up with a solution that's currently being rolled out in Hull. If it works, then realistically, in the next 3 or 4 months, we do have a solution that will make that happen, that as long as we've got the public sector Wi-Fi, whether it's fire, police, local authority, health, some organisations such as here, it's a little bit later because they've got a re-procurement going on with their infrastructure and Wi-Fi later on in the year. You will be able to walk into that building with your laptop, iPad, and it will work. So you haven't got all that hassle of it doesn't work, or you've got to be in our site. Potentially a really big enabler, but again, absolute waste of time if we don't exploit it, and we've yet to exploit that capability. Also the shared access, and that's just shared access for facilities, a desk. You know, to be honest, we've got to be realistic, but we've got to be realistic as partners. So, you know, and work and pilots are happening on that. The Goal Hub stuff is a good example. Single point of access is going that way. We've also got integrated teams, but the main bit is we've got the integrated teams bits and some of them type of aspects dealt with. What we haven't necessarily got is the shared facilities. The last thing we want is, for instance, I can't print anything out. And I need to print it out to give that leaflet to that patient. And it's something simple like that from a shared infrastructure point of view that can really make or break, is it going to work for us? And the other one, which is a national one, is there's a replacement for Choose and Book, the electronic patient booking system. It has to be in there. It's slightly slipped. I think 15th of June is the new go live date, and there is a project that's just coming up on that. But what I would say is the way we currently use Choose and Book, we could get so much more out of that integration. At the moment, we use fairly basic capability on the current Choose and Book, which, to be fair, is a fairly clunky system from both ends, from a GP end and from a provider end. If the electronic booking system is far more effective, let's take the opportunity of linking it into our clinics, make it so when the GP does their bit or the referrer puts it in, that it feeds through into the systems automatically rather than hands-off, which we seem to do a lot of. Now, we had quite a lot for 14 to 16 because it's quite easy for the next 2 years to put quite a bit of detail. It's a little bit vaguer from 16 to 18 at this point in time. Now, this will be expanded upon as part of the plan, but the main bits there is where we've got the record. We need to link specialist systems. So if you have got something such as popping addictions, assuming we're keeping that system, I know we're looking at it, it needs to link together, either real time or another way, or the IAP systems, PCMIS, IAPTUS, and any other IAPT for veterans. Any of these other systems, we need to have that real understanding of our patients and to have it linked together. And linked together as in it is linked, not with sort of, we can sort of show them together, but you've got to log into that system, remember that password and have that access sorted out. Because you know it just will not work. It's got to be nice, easy and simple. You know, successful systems that we use today aren't generally because they're really clunky and difficult to use. They're normally because, you know, they are very easy to use, they're very slick, and they really have thought of how the ergonomics and how people will use it. Become paperless by 2018, it is a target. And we have set that as a success factor. More than achievable, but most of that is how we change the way we work, supporting our staff, and using our systems more effectively. So a lot of the stuff that was in the earlier part of the slides, but it's more than achievable. And I think it's something realistically we actually would want. Isn't it a lot better to have one record rather than we have a mental health record that has so much information, but the paper trail still following the record around whoever's got it at this point in time, if it gets in, or it's been misfiled and there's no check on it, or you can't get hold of it and it's crisis and a patient's in crisis. But if it's electronic, you get that information. That doesn't mean we don't need good resilience and have total confidence that if we did have other issues, we'd still be able to have fallback plans, business contingency and continuity plans. It still exists. But if we go back to the floods in 2007, we had lots of paper records and a lot of them got very, very wet and was destroyed. So paper is not the perfect solution. It's just a different solution, but it can give far more benefits. Interoperability with our local authorities and, I would say, other public sector. This actually might progress far more rapidly than 2016, 18. East Riding Better Care has a theme around an integrated record. I think some of the people in here are members of that particular group. We have developed something called Patient Shareport, Patient Search Portal, which John Paul's team in Crisis are currently doing testing, making sure it's all working all right so we can get the full sign-off of the product. What we have done is we have demoed that solution, which basically all it does is it just puts each one of the records bits, so each System 1 unit, Lorenzo, PCMIS, all that type of stuff, in one view, so you can just see the patient. It's nothing complicated, nothing sophisticated, it's actually quite straightforward. It's something that the IM team with a company called StyleTech put together for around £8,000, which, to be honest, in IT world is peanuts. Council got that demonstrated, and so did Hull 2020. East Riding Council, who are currently matching NHS numbers in the AIS system, I've signed up to use that as an interim portal and load their information in there as well. So we're starting to get a broader view. By loading information in, we can start doing some level of linking systems together. That's one that really could start a couple of years early, and they're really, really keen to do that. So, we don't end up with I don't know where people are in the system. We start getting a view of, at least this is where they are in the system. We might still need to talk to each other on what them care packages are, and we probably do on MDTs and stuff like that. But that one could realistically start happening a little bit faster. And the whole 2020 are very keen on that one as well. And that would really help if we could get some of that linkage with the other organisations a lot quicker, especially if we go paperless. And then there's the other NHS organisations. Similar timescales, and one example of that could well be, here going on Lorenzo, 8th of June, I believe. We've got Lorenzo. How does that all work? How do we share? With System 1, it's eminently possible that we can have a click-through from System 1 Lorenzo, and that then ties in CHCP. It also ties in any AQPs, or when you're looking at the your York services, who use System 1 as well. So we're starting getting some linkage. We have had discussions with York as well from their patient information system, and we have done things in the past with their linking data and communicating. It'll be interesting to see which one becomes the more difficult challenge, whether it's the NHS one or the local authorities side of things. The final bit on them two is the big challenge will be around information governance, data protection, and using it pragmatically and in support of the patient, not as a reason potentially not to do things. Now, I would actually say our IG people are quite open on that type of thing a lot of the time. And we have done quite a lot of work on how we do sharing and such. Not every organisation has the same way of doing things. We do have an overarching sharing agreement with a large number of partners. The door is already there. In 2020, we have done some work around sharing, and this is around fire. There was something to show social isolated older people are more likely to have, on a particular demographics, are more likely to be in a fire or start one than other groups. And one of the pieces of work is there was how can we set that criteria, and how can we utilise GPs to basically refer into fire. So fire can go in and then put prevention in, put alarms in, put extra support in. When that piece of work happened, it also then went absolutely the other way of, well, if we're putting all these fire alarms, the temperature monitors, so can't we do it on being too cold as well? Because more people die because of being too cold than fires. So that's like a whole different discussion around how we potentially could use that type of simple approach to really help the patients that we support anyway, because these social isolated with dementia, long-term conditions, we will be dealing with these on a day-to-day basis, more than likely. But how can we help the wider public sector? Been very effective on the fire side. We were actually getting the ICO in to give us some additional help and direction on that. But in principle, absolutely the right thing to do. But we've got to make sure that the IG doesn't sort of suggest that it stalls us or stops us, because it is to help patients at the end of the day. It's not just to have information to the big brother watching you. Electronic prescribing. It's also another one that might come a little bit earlier as well. We do need to do integrated electronic prescribing. There isn't a lot of systems out there at the moment. It does need to happen. We do have, System 1 does have some prescribing. Lorenzo has a capability for electronic prescribing as well. What we haven't done is really exploited it anywhere near as we could do. And there will be some work that we need to kick off on that. Our pharmacy colleagues have been involved with the Lorenzo side. There are some challenges on Lorenzo for prescribing, and at the moment we aren't necessarily signed up for that approach at this point in time. But we could see the possibility of using it in the future or using interims as a long-term solution. I won't even go into clinical digital maturity index, but if anybody really wants to know about it, I can give you some documentation. It's a bit boring, it's a bit about systems, it's a standard stuff. The final one there, which to be honest we will be looking at later, is what we do with Windows 7 and Windows operating. Costs a lot of money. Can we go open source? Can we do other things? There's some discussions going on with Hull Local Authority at the moment around open source because they're just about to go out to reprocure replacement for Care First. And how do we do that? And a number of open source intranet, extranet type things. So there is some bits and bobs that will come out of that, but you know, we've only just got Windows 7 in. Let's at least get 4 years out of it before we might have to move on. And that will be purely around money. Okay, I think that's, so, I mean, that's the sort of plan. I know it might have been a bit stale, it is in the strategy, but I think it was useful to put a context of what is the direction of travel. But each one there will have projects and pieces of work that will probably involve a number of yourselves in there. And if you know of one, do get involved. You know, it could be quite interesting. There's quite a lot to do. Okay.